Hello everyone, this is a preview in pediatric immunology.
Clinical presentation of X-linked agammaglobulinemia, very easy to remember because of lack of PTK or mutation in PTK. The naive B cells cannot make any antibodies. So lack of immunoglobulin G or IgG will be associated with a recurrent infection with encapsulated bacteria. For example, Streptococcus pneumoniae, Haemophilus influenza, meningococcus, or staph. Lack of IgA, a recurrent infection with enteroviruses, and also lack of IgE, recurrent infection with Giardia or chronic infection with Giardia. Lack of maturation will be no tonsils, no palpable lymph nodes. The lymph node is not working. There is no differentiation in the lymph nodes. Very important to avoid giving any live vaccines to these children. Do not give them MMR, varicella, or live influenza vaccine. The diagnosis flow cytometry will show no mature B cells in the flow cytometry, and if you do antibody level, there is no antibodies. If you do antibody function, like after giving vaccination, there is no antibodies after vaccination. The treatment is simple. These children, they do not have antibodies, so to give them ready-made antibodies, either IV or subcutaneous. Common variable immunoglobulin deficiency is because of lack of B lymphocytes or plasma cells. This disease will be associated with low level of most or all Ig or immunoglobulin classes. Genetics of this disease is sporadic, autosomal recessive, or autosomal dominant. The most important points to remember about this disease appears during adolescence. Very rare to appear before 6 years of age. The level of immunoglobulins is variable. So some of them very low, some of them slightly low, but not absent. The tonsils are normal size or large. They present with recurrent infections, recurrent meningitis, pneumonia, ear infections, and commonly associated with autoimmune complications, and this is high yield. Rheumatoid arthritis, autoimmune hemolytic anemia, vitiligo. Risk of malignancy is high. They may have lymphoma or present with lymphoma. Treatment is simple. Low immunoglobulins to give them immunoglobulin. Low antibodies, give them antibodies, IV or subcutaneous. It is very important to be able to differentiate between these three conditions. Very easy to get confused. Severe combined immune deficiency, or SCID, from the name combined. So humoral, which is B cells and T cells. So this is combined and appears shortly after birth or before 3 months of life, and if no bone marrow transplant, they usually die by 2 years of age. XLA appears after 6 months of life when the maternal antibodies disappear from the circulation, and the common variable appears during adolescence or after, very rare before 6 years of age. In SCID, you will not have any antibodies and also associated with lymphopenia because of T cells. And in XLA, absent antibodies. In common variable, the level of the antibodies are low and variable in levels. So remember, variable, low levels, but not absent. And in SCID, you do not have tonsils, you do not have thymus or very small thymus. In XLA, absent tonsils, and in common variable, the tonsils are normal size or large. So again, recurrent infections, coarse facial features, and thin wall line cavity or pneumatocele. These keywords are very important diagnostic points for Hyper-IgE syndrome. Hyper-IgE syndrome. Again, Hyper-IgE syndrome, or well known as Job syndrome, from the name they have a very high level of IgE. It is autosomal dominant or recessive and also can be sporadic. The clinical presentation: recurrent skin abscesses, recurrent pneumonia with pneumatocele, especially staphylococcal infections, atopic dermatitis or severe eczema, and coarse facial features. Diagnosis of Job syndrome from the clinical pictures, and if you do immunoglobulin level, you will see the IgE level is severely elevated, 100 times greater than normal, so you cannot miss that. The treatment is prophylactic antimicrobial against staph and candida. Eczematous dermatitis require rigorous topical therapy, so treatment of eczema with hydration of the skin and topical steroids. Wiskott-Aldrich syndrome is a very interesting disease, very easy to remember. It is X-linked recessive, affects males or boys only because of mutation in Wiskott-Aldrich syndrome protein gene. And the common presentation of this disease is bloody diarrhea, prolonged bleeding after circumcision, atopic dermatitis or severe eczema, recurrent infections with encapsulated bacteria, and death from recurrent infections by age 6 to 11 years of age. The key words for this disease: eczema, thrombocytopenia, and small platelets. Remember that ITP or idiopathic thrombocytopenic purpura will be associated with thrombocytopenia, but the platelets will be large. In this case, here in the Wiskott-Aldrich syndrome, remember the platelets are very small. So, and this is easy to see in the peripheral smear. So if you do just a CBC with peripheral smear, you will be able to diagnose this disease. And if you see the eczema with it and recurrent infections, and if you do flow cytometry and you see the T cells is affected, this will confirm the diagnosis of this disease. Very important to know the associated risk of Wiskott-Aldrich syndrome because of the T cells, the risk of lymphoma because of EBV infection and leukemia. The diagnosis of this disease, flow cytometry will show decreased T cell number and function, low IgM level. Prenatally can be diagnosed if you have a positive family history, and this can be done either by chorionic villus sampling or amniocentesis. The treatment is skin care for eczema. In cases of severe thrombocytopenia, you need to give IVIG with or without corticosteroids. If the child is bleeding, you need to do platelet transfusion, splenectomy, and stem cell or bone marrow transplants.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you. Presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.